Okay, we started. Good morning, everyone. Today we are going to talk about airway maintenance in anesthesia and ICU practice. Myself, Dr. Smitul, Assistant Professor, SLIPS in Department of Anesthesiology. So, what are the objectives for today? The main purpose of this session is that the student should be able to describe the anatomy of the upper airway, explain the various types of airway devices, describe the methods involved in placement of airways, indications, complications, and preferences. The session plan today includes the introduction, anatomy of airway, various airway devices, indications and methods of placement, complications and preferences, and recent advances. Now, what is respiration? So first, when you inhale, ventilation process takes place. The air goes into the alveoli from where the gas exchange takes place. So then after the exchange of there's a perfusion to the lungs via pulmonary circulation, and then the systemic circulation takes place through which the cellular mitochondria, they get the necessary products. Now, what is the airway? How do you start describing an airway? Going from top to bottom, first there is nose, which leads to nasopharynx. Next is the mouth, behind which you have oropharynx. Then next is larynx, trachea, the right and the left main bronchi, as you can see in the picture, the lobar bronchi, segmental bronchi, the bronchioles, and the alveoli. Now, under normal circumstances, when you are sleeping in awake position, the soft palate is intact, so you are able to breathe and relax. Now, in the case of while you are sleeping or under anesthesia or unconsciousness, there is partial obstruction which leads to snoring. In the cases of subapnea and apnea, there is critical obstruction and total obstruction. That occurs when the soft palate or the uvula is touching the posterior pharyngeal wall. At that point, it becomes critical, so that it can lead to subapnea and apnea. Now, how do you maintain your airway? There's a maneuver called triple maneuver or shortest maneuver, in which you do a head tilt, chin dip, and a jaw thrust. This process will make your airway intact and you'll be able to normal. We also have devices for the same purpose. There's an oropharyngeal devices and nasopharyngeal devices. As shown in the figure, you have different sizes available for the same. Next, we have laryngeal mask airways. The laryngeal mask airway, as the name suggests, it gets settled on the larynx and it will keep the laryngeal inlet open. And the last resort is endotracheal intubation, in which you insert an endotracheal tube via laryngoscopy and keep your respiratory system intact. Next, we have tracheostomy. As you can see in the figure, we have different cartilages: thyroid cartilage, cricoid cartilage, and between there is a cricothyroid membrane. Next, we move on to the tracheal rings. Between the second and the third tracheal cartilage is the usual site for tracheostomy, where we put in a device used for tracheostomy as shown in the figure next to you. Now, what are the indications and preferences? When you want to maintain your airway for a shorter duration, you use oropharyngeal airways, nasopharyngeal airways, laryngeal mask airways, and manually by the maneuver which was shown before, which included head tilt, chin lift, and jaw thrust. Airway maintenance and protection we carry out when there is a risk for aspirations. So in those circumstances, we use endotracheal tubes, which are cuffed, which you can put in through orally or nasally. And the second option is tracheostomy, which is they are cuffed tracheostomy tubes. Now, coming to the basic endotracheal tube, what are the parts of an endotracheal tube? So you have a connector, you have a pilot tubing with a balloon, there is a machine end, and there is a patient end. At the patient end, you have a Murphy's eye located on the lateral wall. Above it, located at an angle, and a cuff. How do you do an endotracheal intubation? Now, the position of the patient is very important when you're planning to do an endotracheal intubation. So, the axis, you should have the laryngeal axis and the pharyngeal axis along with the oral axis in one line. When the neck is flexed and the extension of the head is done, you get a proper position of the patient for carrying out laryngoscopy and inserting an endotracheal tube. Now, what do you see while you are doing an endotracheal intubation? After doing a proper laryngoscopy, this is the picture you will observe in situ of the patient's larynx. The two white structures, as you can see on the figure on the right hand side, those are the vocal cords, beyond which you need to put your endotracheal tube. Now, while doing a direct laryngoscopy, you see the following structures. The base of the tongue, as you can please correlate with the structures seen inside the figure on the center and the one which you can see on the left hand side. So then there is a base of the tongue, you have an epiglottis, the white shining structures you can see, those are the vocal cords, beyond which you have the laryngeal inlet, and posteriorly there are adenoid cartilages. Now there are two maneuvers which are helpful in doing the endotracheal intubation in case of difficulties or under certain circumstances. Now, to improve the laryngoscopy view, we usually what the maneuver used is forward, which means backwards, upwards, and rightwards. You need to push the patient's thyroid cartilage backwards, upwards, and rightwards to improve the laryngoscopic view. The other maneuver is Sellick's maneuver, in which you carry out some pressure over the cricoid against the vertebra. This would lead to compression of the esophagus and which would prevent the aspiration of gastric contents entering into the pharynx. We carry out the endotracheal intubation via Sellick's maneuver in cases of pregnancy and when the patient had already two needs. Now we have different sizes of endotracheal tubes, starting from 2.5 mm, which depends on the external diameter, that is outer diameter, leading till 10. We even have cuffed endotracheal tubes and non-cuffed endotracheal tubes. There are PVC, that is polyvinyl chloride tubes, special curvature tubes, flexometallic tubes. In children up to 8 years, we prefer uncuffed tubes because in children, the subglottic or the subcricoid portion is the narrowest portion. So, in such case scenarios, in the children up to 8 years, we prefer to use the uncuffed endotracheal tubes. As you can see, the infantile larynx and the adult larynx, they have different physical structures. The infantile larynx is cone-shaped, whereas the adult larynx is cylindrical in shape. That is the reason the infants have the subcricoid portion as the narrowest portion, where in the adult, the glottic portion, that is the area where you can see your vocal cords, that is the narrowest portion. Now, once you have intubated the patient, what are the confirmatory signs? First, see the tube, whether you have inserted the tube via the laryngeal inlet under vision. To attach the circuit to the ventilator, ventilate the patient and look the chest for the bilateral equal movements. To ventilate and auscultate. Next thing is we need to see the moisture in the expired air over the endotracheal tube. And the most confirmatory sign is EP fluid monitoring, that is capnography, which will confirm that your endotracheal tube is in situ into the trachea. Now, what are the other chances of dislodgement? Either your endotracheal tube is too inside, that is, it has 1 to 1.5 bronchi. This can lead to one lobe collapse. And the other is you are out of the vocal cords, and this dislodgement will lead to removal of the endotracheal tube. Next is talking about the cuff. What is the importance of the cuff in the endotracheal intubation? It will hold the endotracheal tube in position After you inflate the cuff, once the endotracheal tube has bypassed the vocal cords, at that point, you inflate the cuff. This will keep the endotracheal tube in position. Check whether there is any air leak or no air leak. If there is no air leak, it is good because it will keep your airway protected from vomitous blood or regurgitation. We have two kinds of cuffs. There are low volume, high pressure cuffs, and there are high volume, low pressure cuffs. We prefer high volume, low pressure cuffs since having high pressure cuffs will lead to ischemia, ulceration, and erosion of the trachea, which will lead to healing with contracture and ultimately leading to stenosis of the larynx. So what we prefer is high volume, low pressure cuffs. Now, when do you need to have caution? In cases when the patient has loose teeth or dentures, in coagulation disorders, when you have restricted mouth openings, restricted head extensions, cervical spine fractures, in such case scenarios, you need to be more cautious. Now, when do you carry out the process of intubation? First, you need to give proper, adequate anesthesia to the patient, which includes paralyzing the patient as well. Whether the patient is unconscious and semi-conscious, you need to check for that also. In case when the patient is awake and you are going to carry out a certain procedure, you need to anesthetize the upper airway via fiber optic endoscopy. The next is, what are the indications for tracheal intubation? Anesthetic point of view. So in anesthesia for various surgeries, when you need to have airway protection in cases of incomplete fasting time, or when there is blood or vomitus in the pharynx. Securing the airways in the cases of burns or other airway obstructions. For ventilatory therapies, giving intermittent positive pressure ventilation in case of cardiopulmonary resuscitation or respiratory failure. When the patient is unconscious or semi-conscious, as the patient needs his airway to be maintained properly, and elective ventilation in cases of cardiac or neurosurgeries. Now, what are the indications for nasotracheal intubation? In cases of oral cavity surgeries, long-term ventilatory therapies, we need to carry out nasotracheal intubations. What are the advantages of nasotracheal intubation? You get the field clear, there is stability of the tube, there is less movement of the tube. And what are the disadvantages? Is while you are inserting it through the nasal cavity, there might be injury to the terminates and infections. Coming to laryngeal mask airways. Now, what is a laryngeal mask airway? As the name suggests, the laryngeal mask is going to lay over the laryngeal inlet, that is, it comes in between the oral or the nasopharyngeal airway and the endotracheal tube, and it covers the laryngeal inlet. The laryngeal mask airways are sized from number 1 till number 5. It is technically easy to put, even with the trained nurses at the trauma field. And when is it used? So it is used in cases of failed intubations. We can use second generation laryngeal mask airways, that is BIHER. Now, there can be certain procedures which can be carried out through LMA. Fiber optic endoscopy is one of them. Now, which are the different types of LMA? You have regular LMAs, iGel, ProSeal LMAs, flexometallic LMAs, and intubating LMAs. Now, in cases of difficult intubations, how do you come to know whether there is a difficult intubation? You first mask ventilate the patient, then you carry out laryngoscopy, and then you carry out intubation in cases of normal patients. When it is difficult to carry out intubation, you go for laryngeal mask airways. Even when there is a difficulty in putting the laryngeal mask airways, next is you carry out mask ventilation. You try to maintain the patient over mask ventilation. But when that is also difficult, we need to go out and secure the airway via tracheostomy or plecothyroidotomy. Now, what are the kinds of surgical airways? There is tracheostomy, in which you make an opening into the tracheal wall and insert the tracheostomy tube and maintain the ventilation. Or we can even carry out this thing by percutaneous dilatation tracheostomy. Now, what are the differences between intubation and tracheostomy? Comparing the two, intubation will provide reliable airway in cases of emergency and subglottic stenosis. When we are going to carry out tracheostomy, the advantages are it avoids direct injury to the larynx, there will be better nursing care and suction, better patient mobility, more secure airway, it permits speech, and there is psychological benefit to the patient. Now, what are the indications? In cases of airway obstruction, like infections, diphtheric infections through Ludwig's angina, laryngeal tumors, and trauma, and electively, when there is anticipated prolonged ventilatory therapy, in cases of urgent intubation to carry out tracheostomy, and for anesthesia for laryngectomy in cases of carcinoma larynx. Now, what are the complications of tracheostomy? Most common complication is bleeding, surgical emphysema or pneumothorax, wound infection, that is, it can lead to tracheocutaneous fistula. Second, tracheoinnominate artery fistula, tracheal stenosis, and tube-related complications like displacement of the tube or block by secretions. What is needle cricothyrotomy? In cases of emergency, we can secure the airway by needle cricothyrotomy via a special needle used. It is nothing but a wide bore IV cannula. It can be carried out in patients more than 12 years of age. So to summarize everything, what did we learn? What we have to keep in mind, the general anesthesia techniques and agents, they suppress or interfere with all resistance. The eternal vigilance, that is monitoring, is the price of safety. The recovery depends on the type of anesthesia and the agents used. And the preventive measures and appropriate management of complications is essential for safe conduct. We have carried out the entire lecture using these two books. Thank you. Stop sharing.